quiet minutes of that happening, and then Ryan and Ashley on our team will let us know when we are
recording in progress,
ready to go. Thank you so much.
And we are good on my end.
Thanks, Ryan.
And good on my end.
Okay, thanks so much, Ashley. And thanks to everyone who has joined us this morning. We are at a new day and time today. We moved the time of this briefing to avoid conflicts with the briefings that are held by the state and local health jurisdictions. So we're trying to find a time that works for everybody. So we appreciate you joining us today and your continuing interest in the story of how Washington's hospitals and health systems are responding to the COVID pandemic challenge. My name is Taya Briley. I am the Executive Vice President for the Washington State Hospital Association, and joining me today are some panelists who will help provide a fuller picture of what is happening with the response effort. They are Jeannie Eiler, who is the Chief Nursing Officer for Pullman Regional Medical Center out in Pullman, and Charlene Tachibana, who is the Senior Vice President for and Chief Quality and Safety and Patient Experience Officer for Virginia Mason Franciscan Health, and Dr. George Diaz, Division Chief of Medicine and Medical Director of Antimicrobial Stewardship and Infection Prevention for Providence Regional Medical Center, Everett. So you're in really good hands today. We've got 2 nurses and a doctor here to speak with you. And before I turn it over to them, I wanted to provide some additional background information and grounding for a briefing. So first, I will say that we are glad that the overall rate of increase in COVID cases and hospitalizations is beginning to slow. In some areas of Western Washington, such as King, Pierce, and Snohomish counties, the trends of hospitalizations are even going down a bit. However, we are bracing ourselves for the second chapter of the Omicron surge as it hits Eastern Washington and Idaho. Overall, in Washington state, we've seen the daily hospitalization numbers for COVID remain above 2,200 this past week, with a high of 2,300. We saw an average of 2,286 COVID confirmed hospitalizations this past week compared to the prior week's average of 2,148. This is a roughly 6% increase in a week. This is an improvement, though, from the last few weeks when we saw much larger increases from week to week. We averaged 260 new COVID hospitalizations each day this past week and roughly 18 to 30 COVID-related deaths. The average number of patients on a ventilator was 155, which was a 14% increase when compared to the prior week's average of 136. And so these are really sobering numbers. And this is following what unfortunately has become sort of a well-worn trend of, the number of COVID cases goes up, then the number of hospitalization goes up, the number of folks on ventilators go up, and then unfortunately we see more deaths. This is following the pattern that we have seen time and again. Last week was an extremely rough week for all those in our state who needed access to life-saving hospital care. Hospitalizations were trending up, and staff continued to call out sick because they had either contracted COVID or they were having to isolate due to exposure. Each day, we have been seeing an average of 800 to 850 new COVID cases among our caregivers. For the first time in the pandemic last week, the Washington Medical Coordination Center triggered its guaranteed acceptance protocol. This protocol comes into effect when all hospitals are full to the point of needing to refuse patients. It's a commitment of our largest hospitals and health systems that no patient who is in dire need of care will go without it. It is unique in the nation, and it's made possible by the coordination, cooperation, and dedication of our care providers. The protocol was in place for about 3 days, and during that time, it was used to place 2 extremely ill patients who otherwise would not have received life-saving care. Capacity then eased to the point that the protocol was stopped. To be clear, the Washington Medical Coordination Center is continuing to move patients around the state to level load, and this is still needed. This morning, some of our facilities were reporting that they remained at over 150% capacity. But the guaranteed acceptance protocol requirement has been turned off. We are so grateful to our partners at the Washington Medical Coordination Center for their clinical and logistical expertise that allows the process to work. We are concerned about the rising cases and hospitalizations in Eastern Washington and Idaho and how they will ripple across Washington state. And as I said earlier, hospitalization numbers are trending down in parts of Western Washington in the past week, but overall hospitalization numbers in Western Washington remain very high. Meanwhile, in the past week, we've seen a 38% increase in COVID hospitalizations in Chelan County, a 31% increase in Yakima County, a 23% increase in Spokane County, and approximately a 15% increase in Kitsap and Clark counties. In fact, Spokane's COVID hospitalization rate has almost doubled in the past 2 weeks. Roughly 2 weeks ago, they were at around 80 hospitalized COVID patients and now are at over 160. Increasing hospitalizations on the eastern side of our state will impact Western Washington hospitals that are already stretched and stressed. There is not as much critical and high acuity care available for very sick patients in Eastern Washington. So Western Washington typically absorbs overflow from Eastern Washington. So we want to make sure that we're able to flex and accept those patients as we need to. Adding to the complexity is the increasing strain on the Idaho hospitals. Yesterday, Idaho declared crisis standards of care in 3 health districts. While these districts are in the southern regions of Idaho, it could still impact Washington hospitals in at least 2 ways. First, because of geography, there are normal transfer patterns between some Washington and Idaho border hospitals, especially in Southeast Washington. Our Eastern Washington hospitals could be tapped to take some of these patients. Second, any patient who comes to the emergency department must be screened and stabilized it's a federal law requirement. And as a result, if an individual from Idaho presents on their own to a Washington emergency department, they cannot be turned away. So we are concerned that crisis standards will spread north in Idaho. In the prior crisis stage, when Idaho declared crisis standards of care, it began in the north and then spread south. And Washington hospitals were definitely affected. And so we want to make sure that we are doing all we can to care for our community members, even as we're dealing with increasing caseloads in various areas of our state and in our region. I wanted to turn to a little bit of a different topic that we discussed last week that has direct implications for how we are able to manage the uptick in COVID cases and the surges that we're seeing driven by Omicron and probably some other variants in the future. There is a bill in the Washington State Legislature that would impose inflexible nurse-to-patient ratios on Washington hospitals. And I want to reflect here for a moment on what we in Washington have achieved in our state so far. Unlike other states around us, our hospitals have not gone into crisis standards of care, which means rationing of care, that some people will not receive care. And we have been actively level loading patients since the summer of 2020 with the help of the Washington Medical Coordination Center to make sure that this will not happen. Ratios of the type that are proposed would end level loading because hospitals would need to reserve all their staff and their beds for their own communities. If we have these ratios in place throughout the pandemic, many Washingtonians who were served by hospitals outside their community would have lost their lives. California, the only state in the country that has nurse to patient ratios right now, could not lawfully have a system like ours, as was discussed last week. We saw the specter of ambulances lining the streets in Los Angeles with dying patients who could not get into hospitals as a result. This week, we've seen further reporting about the grim situation in California hospitals. We don't want this to happen in our state. Last week, nursing and hospital leaders around the state testified to the state legislature about their deep concerns related to these proposed ratios. As more groups learn about the legislation, we are hearing more concerns about how the proposal would impact not just hospitals, but other critical parts of our healthcare infrastructure. That includes long-term care, dialysis centers, mental health centers, and outpatient settings. All of these settings compete with hospitals for nursing resources. And if hospitals have ratios, that means that more of these nurses would need to be hired at hospitals, which often offer the most well-paying of nursing positions, and that has the potential to deplete supply from nurses in these other care services. And in listening to the testimony on this bill last week, an important element seemed to be missing from the conversation, and that is educating enough nurses to meet patient care demands. Ratios will not magically create more nurses. More investments in nursing education, an area that has been chronically underfunded at both the state and national level, will create more nurses. Currently, Washington hospitals, these are hospitals alone, not other areas of the healthcare system, are reporting a need for 6,000 more nurses. In the 2019-2020 academic year, the most recent one for which we have data, the state turned out just over 2,600 new nursing graduates. Those graduates are needed to go to work not just in hospitals, but throughout the entire healthcare system. Some will move away. We know that surrounding states rely on Washington to educate healthcare providers. The math just does not add up. And there's a reason that so few nursing graduates are being produced. The educational path to become a registered nurse is expensive and it's resource intensive. Without state and federal resources to provide support, education institutions cannot afford to add more training slots. There's an idea that there aren't enough nurses because the jobs are undesirable. In fact, these are well-paying and rewarding jobs, and it's competitive to get into nursing school, and hundreds of qualified applicants are turned away every year. We simply are not producing enough staff to provide care throughout our healthcare system. And schools offering nursing training need financial support, and I want to share just a little bit about my own experience to help highlight this fact. I am trained as a nurse, and I am trained as an attorney. My nursing education required hundreds of hours of clinical instruction, time in a lab practicing skills, time caring for patients in the hospital under the supervision of a preceptor. In contrast, my legal education could happen in a single building with one instructor lecturing to hundreds of students at a time. This is a much more affordable model of education. And until we see the necessary investments of nursing education, with the increased training slots, we won't be able to see the increases in number of nurses that we need to care for our patients. As we described last week, we are urging the Washington State Legislature to focus on funding for nurse training as the best strategy to address the nursing shortage. Before I conclude, I wanted to move on to a couple more pieces. One of them has to do with some of the things that are starting to ease pressure on our hospitals, and we're happy to share that some of the relief measures that were ordered by Governor Inslee are beginning to fall into place and have an effect. For example, some of the National Guard teams are on the ground and helping to provide relief in emergency departments that were especially hard hit. And the state is moving the assessments required for difficult to discharge patients forward at a faster pace. State and federal relief on testing is also starting to come online with the ability to order tests by mail and administer them at home. This is much needed to take pressure off of emergency departments that we're seeing folks present just with the request to get a test and learn whether or not they had COVID. And so I will ask our panelists to share any experiences they have with these relief measures and how they might be helping their hospitals. I want to speak specifically to the topic of personal protective equipment, and especially N95s. This is top of mind because the governor proclamation on non-urgent procedures included a requirement that all hospitals operate with conventional levels of PPE. The nation is still experiencing supply chain challenges with PPE, especially N95s. Being in conventional use requires following labels on the piece of PPE, and for N95s, that means discarding the mask after every patient interaction. Many hospitals have been operating in contingency PPE status for N95s, which allows for a mask to be discarded after a shift. The state has said its stockpile is available to hospitals, but often the state's supply does not have the small sizes or the brands that our hospital staff need. WSHA is stepping in to help members by placing a large order of masks with 3M. And to be clear, it's been difficult to get these masks, but by coordinating an order across the state and highlighting the governor's requirement, we were able to access additional supplies. And 3M has been a good partner. WSHA received orders from 27 hospitals totaling just over 1 million requests for 1 million N95s. And we will be working to get those supplies in over the next couple of weeks. And to conclude, I just wanted to mention that we are starting to get questions about what will be coming next that will affect hospital capacity. One thing we know for sure is that the governor's proclamation on non-urgent procedures will be in place until February 17th. And so until that order is rescinded or we reach February 17th, that means that hospital services will be limited to those who most need them. We know that variants are continuing to emerge, and Dr. Diaz may want to talk about this more. There's a variant BA2 that's circulating in Denmark that seems to be taking the place of some of the original Omicron. It's unclear what the implications are for transmissibility and how much illness will be caused. But I do want to say that regardless of what is happening with variants, since vaccines were rolled out a year ago, we know that 90% of hospitalizations and deaths would have been preventable, 90% with a vaccine. So COVID will continue, the risk will continue. We encourage people to get vaccinated and boosted. And we do not want to see folks becoming a statistic of this terrible disease. So with that, I'm going to conclude my piece of this. I'm going to go ahead and turn things over to our panelists. If you have questions, please go ahead, put them in the chat. And after our panelists are concluded, you're also welcome to come off of mute and ask questions directly. And we're going to go ahead and start with Jeannie Eiler, who is the Chief Nursing Officer of Pullman Regional Medical Center. So Jeannie, we'll go ahead and start off with you over on the eastern side of our state. Thank you so much for being with us.
Thank you, Taya. It's my pleasure to be able to share a little stories from Pullman Hospital in Pullman, Washington, home of the Cougs. So we are a little different than many hospitals. We're a critical access hospital. That means we have 25 maximum inpatient beds. We do full service OB, surgical services, med surg, and we do have a 4-unit intensive care unit. Our intensive care unit is really where we have cared for our COVID patients, and it has had big surges. Last fall was our last big surge, September and October, of COVID patients. But we still are seeing a surge of very sick people, not COVID patients in particular, but I do believe that we're seeing higher levels of very sick people because people have delayed care. I think part of that goes to the procedures, trying not to do things until they're urgent. And so then we're doing like bowel cancer surgeries. We have one scheduled for today that she'd been delayed and felt like she couldn't get it anywhere else. So we're just nip and tuck every day. We're meeting, we've got these huddles twice a day at 11 o'clock. We're looking at what's on the schedule for surgeries, inpatient surgeries tomorrow, and what's our staffing, how many discharges do we have, how many calls have we had come in. Our house supervisors are getting about 3 to 5 calls a day from other hospitals in Idaho or Washington because they're looking for a bed. When we have not been very full. In our average length of stay for an inpatient is under 3 days. So the turnover of patients is very rapid. And so when we look like we've got 6 open beds on today, by tomorrow morning, depending on what's happening in our emergency department and what's happening with transfers in, it is very fluid. And so it's taking all of us to just make sure that we are aware. We're trying to balance getting these people the surgeries they've been waiting for months, and taking care of the emergency patients who come in the doors, and then trying to be good neighbors with Gritman in Moscow, Idaho, or St. Joe's. St. Joe's in Lewiston, Idaho is a much bigger hospital, but they don't have specific specialties. We have many calls for specialties that we have here in Pullman that they don't have. And so we try to accommodate those. And we feel like we've done a really good job of just trying to balance all of those pressures. And then, like everybody, our staff are dealing with their own health issues. I think about in 2020, we had several of our ICU staff that put off surgeries that they needed really bad. And then in 21, they just had to do it. And in fact, it's added complications to their recoveries because they delayed their own care, so they didn't leave their coworkers short. And then we've got staff who deal with those issues of school closures, daycare closures, and then they're trying to homeschool last year, trying to homeschool kids and still work full time. So we've been trying to, as an employer, really be supportive of understanding that staff have got a lot of pressures outside of work too. So we've been pretty creative in how we've put together this on-call schedule that staff can say, I could be available on this day, which would normally be my day off, and sign up for days so that they know if we have a sick call or we have a surge, that we've got a call system all ready to go. And our staff have really appreciated that way they know at the end of their shift, if they're not signing up to be on call, they can go home, they can have their own personal time. So it's put some control into that for our staff. One of the other benefits is that we staff at higher levels than most hospitals. And so we've had that little bit of cushion that has been very helpful as we've dealt with higher levels in our ICU and in our emergency department in this last year. I think some of the other areas that don't often get talked about are places like our lab. You know, we have 12 employees in the lab and have just recently had 3 resignations of our laboratory technicians. And just like nurses, lab people are just not out there. And so we are kind of scrambling, and our lab is really impacted by trying to offer all these different tests that are required by COVID or anything else. One of the ways we have taken the pressure off of our lab is that we partnered with Insight Pathology, and they offer a lot of the lab COVID testing as outpatients. And so that has been very helpful. Insight has been an awesome partner, and they're consistently getting their COVID testing, PCR tests, turned around in 24 hours. So we're really excited about that. our PPE is strong, but the supply chain, it hits us in other ways that you wouldn't even think about. For equipment that keep a CT scanner up and going, for lab test tubes that you have to run specific kinds of lab tests in. It's kind of amazing how intertwined all of this stuff is. We're pretty excited that we're trying to deal with the day-to-day nuances that are happening, but at the same time, we're welcoming nursing students in from Walla Walla Community College and from Lewis and Clark State College in Lewiston, Idaho, because we recognize we've got to keep the pipeline of nurses going. And that is really key. We're trying to train nursing assistants and RNs all the time so that we can not be contributors to this huge nursing shortage that we knew was happening. We've been talking about the nursing shortage since the 90s, but COVID really exacerbated it. People retired, people just got exhausted and tired. And so the shortage is real, and hospitals are trying every aspect that they can to recruit and retain all of their staff, nurses, lab techs, imaging techs. It takes that whole team, and it takes a lot of creativity and a lot of effort to make it the kind of work that people want to do.
Thanks so much, Jeannie. Appreciate those comments. And I think you got to one of the specific questions there on PPE. Charlene, I'm going to go ahead and turn it over to you if you go ahead next.
Myself unmuted there. Well, I want to thank you for the opportunity to be here today and to talk with you a bit about the work that we're doing at Virginia Mason Franciscan Health and managing this current surge. Like others, we have been somewhat overwhelmed by this. We are currently just under 400 COVID patients across our 8 facilities here in Washington State. And our peak last week was well over 400, which is about double what we saw in the Delta surge. So clearly moving into some really unprecedented times. And we were so cautiously optimistic when we saw things plateau over the weekend. And then the Monday numbers looked like they were beginning also slightly to head down. I want to just give a shout out to our healthcare workforce because they have been shouldering such a burden here. The facilities have been well over 100% occupied. And that means that we have more patients than we have beds to put the patients into in typical locations. So we're providing care in areas that are more difficult to provide care in, that don't have the normal flows associated with them, that might be boarded in the ED longer than what our patients and our staff are comfortable giving care in. And that puts added strain on our workforce as well. So just a big call out to those who continue to serve and are working as hard as they can to keep our communities safe. The influx of COVID patients has certainly been a cause for our overcapacity census. But we are still backlogged and trying to get patients moved out of the facilities as well. So these patients who no longer need hospital care and are waiting to get into our skilled nursing facilities, beginning to see some movement there, but we have a large backflow that we still need to clean out or clear out, if you will, of our facilities in order to open up more capacity. In some of these locations, you know, that can be 40 to 50 patients who are waiting to be discharged, and we're not able to get them out. So any relief that we're beginning to see is so greatly appreciated in order to get the others in. As Taya mentioned, the vast majority of cases still requiring hospitalization are among the unvaccinated, and a small percentage of those who are vaccinated or boosted who require hospitalization are those who are immunocompromised or really have comorbidities. So this is such a clear picture, if you will, on who is getting COVID and who is needing this higher acute level of resource. We're doing all that we can to balance our current staff capacity and meeting our patient needs. We have what's called mission control that meets on a daily basis and operates to look at capacity and patient needs across our 8 hospitals and try to direct patients to where we have the resource that can meet their needs. So that has been a huge benefit for us, in that we're able to distribute within the system some. We have everything from a critical access to large medical centers, so being able to move them and provide the care that they need has been of benefit to us in trying to get those resources leveled. We're doing a lot of work trying to help our community understand what they can do to help us. And so those things include not going to emergency rooms unless you are in an emergent situation. So if care can be provided elsewhere in your primary care office, in an urgent care facility, we encourage people to go there. Likewise, if people do need an emergency room, we want them to come, and we want them to come early and get their care that can only be provided through emergency services. We ask people not to delay their routine health visits. It's really important right now that people do all they can to stay healthy and to avoid needing a hospital. And so, we're encouraging telehealth visits to take place. That still remains a great option for patients and has been a really convenient tool during times like this in order to keep people getting their services met and staying healthy in order to stay out of the hospital. We are running boosting campaigns again, getting people boosted who are eligible to be boosted. And some of those have opened up to families and to children as well, so that in the workforce home, we can get people safe. We're seeing so many family gathering exposures or exposures that took place over the holiday or when people are still connected with one another. And we want everybody to stay current on their vaccine status there. And then, as Taya mentioned, we have been also really encouraging people to get their masks upgraded, not only here at work where we're moving them all into N95s, but also those in the public and in our communities. That we're really past the point where cloth masks are an option anymore. We have to get people into medical masks and help people learn to wear their masks around their mouth and their nose and keep them well fitted. So really looking at those preventative options as well to try to turn this tide on where this pandemic has gone. So I think I'll close there unless there's anything else.
Yeah, thanks so much, Charlene. Great perspective from one of our systems that covers a lot of geography and cares for a lot of patients at a high level of care. I want to go ahead and turn it over to Dr. Diaz to talk about what's happening at Providence Everett and in his system.
Thank you. Thanks for having me. So this week has been very complex, like the last few weeks have been for us. We are a 600-bed hospital. Right now we have about 200 COVID patients in-house, with the prior greatest peak of patients in our hospital being about 138. So what Charlene was saying about really drastic increases in hospitalizations is definitely true. The result has been that we've also, canceled surgeries, and these surgeries are going to have a cost in the future. These are not cases that were medically unnecessary. These are all medically necessary cases to do that are being canceled. And these could be cardiac surgeries where someone could have a heart attack. It could be tumors that need to be removed that now could progress. So these are surgeries that are being postponed that will have a cost to people in the future. As was mentioned earlier, unfortunately, 90% of the admissions are in people that are unvaccinated. And right now we are in sort of two sets of crises in our hospital. One with patients that we can't discharge because there's nowhere to send them, as well as a staffing crisis where many of our staff members are out sick with COVID, mostly exposed at home and have to care for children or loved ones. And were 90% of these hospitalizations from our hospital removed, we would be in a much better position to provide care. So the lack of vaccination that is currently exists in our community is drastically affecting other people by delaying their care and making it harder to care for patients. With respect to the long length of stay patients, these patients that are in the hospital that are ready for discharge and have nowhere to go, these numbers remain very high. In our facility, right around 100 patients. And some of the work that's been done by the Washington Hospital Association and government is starting to help. But the reality is that there's simply not enough beds out in the community to house all these patients. This will be an ongoing problem for not only us, but I think for our entire state as we move forward with an aging population, that the problem is just going to get bigger. And without further support of creating more beds outside the hospital, this will continue to be a huge problem going forward. With respect to PPE, we are using N95s for our staff. Right now, we do not have any drastic shortages, but certainly at the rate that we're consuming PPE right now, it would potentially be a problem, and we welcome the orders that were put in by the Hospital Association for additional N95s. With respect to nursing staffing, this has been a major issue for us, and I think across the state, as Charlene had mentioned, there are many nursing staff members that are out, and we have had to be very creative to be able to pivot patients, nurses to different areas. So now that surgeries are canceled, we've moved those perioperative surgical staff nurses to other units to help support the care of these large number of COVID patients, as well as other areas. This flexibility in being able to move staff around and modifying ratios is the only way that we've been able to care for all the patients we have in our hospital. As was mentioned before, I think being strict about nursing ratios at this moment in time would not allow us to provide care to these patients. So we're glad that the Hospital Association is supporting that position. Other things that we're working on right now, we thankfully have gotten some new antivirals available to treat people before they're hospitalized. And so we've set up a program here at our hospital to deliver both oral antivirals as well as atrobovab infusions in the outpatient setting. We don't want this to be done in our ED setting, and so we've moved it to an outpatient site where we can do these infusions with the hope of being able to reduce admissions by providing this care outside the hospital. There are supply issues. Thankfully, right now we haven't run into that problem quite yet, but we're certainly concerned about the supplies of these monoclonal antibodies coming and oral antivirals coming to us. We're also looking at starting outpatient remdesivir infusions, as that recently got an EUA from the FDA to be able to provide that treatment as well in the outpatient setting. So those are exciting treatments that we have that we're starting to operationalize at our hospital. With respect to, there was a question about the new variant BA2. It's been reported in numerous countries now, I think over 40, and in some countries it's a predominant variant. We know very little at this point in terms of sort of outcomes and what will happen next. But at first glance, it appears it's not causing worse disease than the original Omicron variant, which I think is probably good news, but it's far too early to know if BA2 will cause surges down the road. We just don't know that, and our state is doing sequencing, so hopefully we'll have some data about how what the current rate of progression is. There have been relatively few BA2 cases in the US described so far. We just don't know if it's going to increase in the predominance amongst all variants that are currently circulating. Other issues that were brought up, I think that the governor did provide National Guard support, and I think we received 10 National Guardsmen in Everett. They're able to help us non-clinically, meaning they can't do any direct patient care. So for an example, at any given time, we may be 40 to 50 nurses down at our hospital. These National Guardsmen can, for example, they're helping us with doing N95 fit testing, they're transporting patients, they can do some limited work with patients that are non-clinical, taking information down, etc. So we certainly welcome the help of National Guard, because every person that comes to help is a help, but it's not really in terms of staffing for where we need help, which is nursing and CNAs. It's not having a huge impact in that regard. Thankfully, right now, we've seen the numbers stabilize, at least at our hospital, in terms of admissions. We haven't seen a big decrease quite yet. And we're very concerned about what's going on across the border in Idaho. We know from prior experience that their hospitals get overwhelmed and patients come and ultimately end up in Western Washington. So that's highly concerning, as we are pretty full at our hospital right now in terms of hospital admissions. And so that's a very big worry we have of our neighbors needing help when we're, pretty full ourselves already. I think that's really all I have to mention right now. The two takeaways, I think, the biggest issues that we have are with discharging people where there's nowhere to send them, and nursing staff challenges remain a huge problem for us. Thank you.
Thank you very much, Dr. Diaz. Yes, the difficult to discharge issue does persist. We are grateful that the state is taking some steps to move patients through a little bit faster by completing assessments more quickly. We also really would like to see policy changes made in our state law that will allow that process to move much more efficiently. I see a question here about the blood shortage, and that definitely has been the subject of a subject of conversation, and it is affecting, at least just for me listening to one of our hospital coordination calls this morning, where some patients have been routed that need care. I'm curious if any of our panelists can speak to how the blood shortage is being felt in their facilities.
I can speak a little bit to that. So we know that there's a crisis in blood shortage, and every pint of blood that we use is carefully evaluated to make sure that it's absolutely necessary for that particular patient. We already had a very aggressive blood concentration program in place even before this crisis, so we really were careful with blood transfusions. But we would certainly ask that the public help people can donate blood at the blood bank, and that is really going to be the only way to get out of this crisis. Thankfully, we have not had any issue where there was a patient that was hemorrhaging from trauma that we couldn't get blood. But certainly the tank is quite empty right now across the state for blood. So we really need the help of the general public to donate blood to get the supply back up.
Thank you. We had a question here about the effect of bringing in resources like the National Guard. Thank you, Dr. Diaz, for responding to that. I didn't know, Charlene or Jeannie, if you had, with respect to any of the mitigation measures that the state has been able to bring online, any comments on whether those have been impactful for you at all?
So I'll just respond. We were not recipients of the National Guard. Others in our locations, in our close locations have been. We have used some of the state offered staff, though, the GSA staff, and they have been, we've just been so grateful to have them come in and supplement our care and be part of our care team. So very grateful for that.
We have not been the recipients of any of the National Guard assistance either.
Thank you. Okay, and then there's a question here about are Eastern Washington COVID hospitalizations following similar patterns to those in Western Washington? By that meaning milder cases, less folks in the ICU, and more in acute care. Also, are Eastern Washington hospitals seeing differences in proportion of hospitalized patients who are vaccinated? I will just make a quick comment to say, even if we've got less folks going into the, overall less folks proportionately with Omicron that are needing to go into the hospital, because so many people have contracted Omicron, that is driving some pretty significant numbers. So I want our panelists to speak to this too. So any comments on that from our panelists?
Well, I think that I would just go with that first question. Eastern Washington is experiencing just exactly what Western Washington experienced, that the majority of our patients that are hospitalized and in the intensive care unit with COVID are unvaccinated people. And so I think it's just a slam dunk as far as what I can see across the nation. And while this variant seems like the vaccinated have been more likely to get it than they were the other variants, it still seems like for the majority of our staff I can speak to who have gotten this Omicron variant, they've weathered it very well. They describe it more as just a cold, but the impact that it has is that then we've got these quarantine measures. So we've got this staffing shortage because we have to have these people not here to spread it to our patients and to each other. And so even though and healthcare workers are notorious for working when they have a cold or are sick. And so in most times, I think many people would be coming to work with these symptoms that they have, but because they test and they want to be responsible and we want them to be responsible, it adds to the labor challenges.
For sure. Thank you so much, Jeannie. Maybe a question for Dr. Diaz on our, I think this is the BA.2 variant. Isn't there concern about it being stealth, meaning harder to detect or not showing up in some PCR tests? Maybe you can shed some light on that.
Yeah, that's been the concern, I think, all along, that a variant comes along that we can't detect easily on our PCR or antigen testing. I don't think we really know enough yet to see how the assays in the United States behave against this new variant to know for sure. But if it were, for example, a variant that's not easily detected by PCR or antigen testing, that would pose a significant risk in the US because, moving or pivoting to different tests or platforms across the US would be very, very difficult to do and operationalize. You'd have to get, the manufacturers of these tests to update their assays, validate them, and distribute them in large quantities across the US, which would be an enormous undertaking. So there's certainly a very big risk if we can't detect it by our usual methods, and we're not sure if that's the case yet or not.
All right, thank you. And a question about how are hospitals handling the lack of staff from the latest wave, and how concerned are panelists that this latest wave and subsequent rush of non-urgent surgeries and when it subsides will exacerbate burnout and lead to even more healthcare workers leaving the industry. So sort of the scenario that we've been in for the last 2 years of just when we get through one thing, another thing hits. It's really hard on frontline care workers. So would love to hear from the panelists about any thoughts they have on managing this sort of continuing strain.
So I'll say a few words. We've really been looking at a variety of ways to support our frontline, even in the day-to-day types of things. So those of us who are no longer frontline caregivers, getting out and helping in ways that we can, we call them helping hands. You know, it may be running for supply or trying to get something else, or trying to keep our caregivers focused on giving care and not all the other things that sometimes takes their time and energy away. So doing that, looking at ways to help them have respite and to at least get their breaks, to get into a room by themselves where they might want to meditate or do something that can help them rejuvenate for a few minutes, making certain that they're not overworking. I mean, we need their time and we need them to work overtime, but we don't need them to be exhausted. They have to take time off and get a good night's sleep and be able to take care of things at home in order to be here working again. So, you know, we're looking at multiple ways, looking at different ways to put the care team together and to shift some duties around to take advantage of other professions who may be able to contribute where the burden is the hardest right now. So just a variety of different approaches to how do you keep people physically and emotionally healthy in order to serve our patients.
Thanks, Charlene. Okay, I've got another question here. Maybe Dr. Diaz, this one can go to you about, has the state distributed guidelines on administering antiviral medications available to treat COVID since supply is limited?
Yes, so the NIH and IDSA have both come up with sort of tiering for how to use these new antivirals in the outpatient setting. On top of that, the Department of Health has collaborated with most of the major health systems in the state to come up with interim guidelines to how to use these antivirals in the setting of low supply. I think, you know, most of our health systems around the state are obeying that or even using possibly stricter criteria. So that work to come up with state guidance was collaborative with the Department of Health and is what we're using as our basis for using these antivirals. And it's basically trying to risk stratify and use these antivirals in patients that are in the greatest need or greatest risk for requiring hospitalization.
Yeah, and just a quick comment on this from my perspective. From the very beginning, when antivirals were available, Washington State has been extraordinarily thoughtful about how to make sure that these therapeutics are available in an equitable way, and has done a good job working with care providers to make sure that these therapies are available to those who most need them. And the Hospital Association has been and continues to stand by to play whatever role the state would like us to in terms of helping to move therapeutics around and help communicate between hospitals about where they might be needed. Okay, we've got a couple of additional questions in here. One is about Idaho's crisis standards of care designation and how it's expected to affect Eastern Washington's hospitals, especially as they experience their own Omicron peak. And I think that is something that we are really keeping a close eye on. Jeannie, if you have any further comments, would welcome them.
Well, I think we've got such great relationships with our other hospitals just across the border in Moscow and in Lewiston. There are 5 hospitals right here on the Palouse and down in the Lewis and Clark Valley, and we're in close communications. And so I think St. Joseph's in Lewiston and Gritman Medical Center in Moscow will be the first to kind of feel what happens down in southern Idaho. And and that is often where we are getting our transfers from. We're trying to be really good stewards all throughout Washington as a part of the WMCC. But we also feel like we are in community with these other folks who are just under 30 miles away and have been able to give and take really well. I think this other question here, it is the somewhere between 19 and 35 is the majority of the people that we're seeing test positive right now. And so it may go down lower than that because I believe that high schools are also being pretty strongly impacted. Pullman Regional has not asked for National Guard resources. We feel like with all of our community partners that we're doing okay. It's not easy. I think we're doing a lot of the same things on a smaller scale than Charlene was talking about, and doing okay, but really appreciate the community support that we've had from here. We've even added some of our restaurants that have been severely impacted by COVID have been so generous to our staff of giving gift cards and food and bringing food in to just really try to, again, take the burden off of staff. All of those kinds of things are really appreciated by those frontline workers.
Super, thank you. And we have just a couple minutes left. I think we made our way through all the questions that were in the chat, but if anybody is feeling like we didn't get to one in depth enough, let us know. Any final comments from our panelists? Okay, I'm going to go ahead and call us to a conclusion here. Thank you so much to Dr. Diaz, to Charlene Tachibana and Jeannie Eiler for being on today. Thank you to all of you who joined us. And we just will conclude by expressing our deep appreciation for all of our frontline care workers who are continuing to make their way through this latest surge. We'll be back next week, and we're planning on every other week after that for these briefings. But of course, if something more urgent or timely pops up, we will go ahead and schedule in an additional briefing. So sorry, back the week after next. So no briefing next week, and then every other week starting the week after next. Okay, thank you all very much.
Thank you, Tim.